Dr. Anthony Davis is along with us, and you'll recognize that name because he is a Russellville native, but also he is a Russellville physician, a neurologist here locally. Dr. Davis, good to visit with you and we're going to talk a little bit about Alzheimer's and about dementia. But before we make that leap, let's talk a little bit about you. Remind folks about who you are, and you shared with me this is hometown for you, and I know for those people that are in need of neurology specialty in their family, you would be more than happy to visit with them.
Absolutely. So I was born in St. Mary's Hospital in 1978 and went K through 12 at Russellville schools before going to the University of Arkansas in Fayetteville, where I did 4 years with a psychology degree, and then I moved to the University of Arkansas for Medical Sciences in Little Rock, where I got my medical degree in 2005, and then completed neurology residency in 2009. I worked for Baptist Hospital as a hospital neurologist for 3 years before coming back to Russellville because there was a great need here. There was no neurologist anywhere between Conway and Fort Smith, and so that left a big gap and a big need. And so we were blessed and honored to be able to come back to my hometown.
For those people that would like to get in touch with you, remind us about where your office is and a phone number if you'd like.
Absolutely. So we're at 220 North Phoenix, which is at the base of the new overpass that goes over the railroad track. We're right off of Main Street, very close to the hospital there between Parkway and Main Street. Our phone number is 479-880-0101.
When people think about a neurologist, I think a lot of times they think about head injury, they think about stroke, but more and more individuals and families are thinking about Alzheimer's, about dementia, because, of course, its origins are in the brain. And you and I had a really interesting discussion before the interview a little bit about this. And your desire with our interview and forthcoming interviews is to demystify, if it's possible, demystify some of the questions and concerns people have about Alzheimer's, about dementia. Before we start answering some of those questions, you illustrated to me one of probably the most difficult things about these myriad of diseases is the fact that they're not easily diagnosed.
So to get firm for sure diagnosis, unfortunately, requires an autopsy, and of course I don't prescribe that, but that requires looking under a microscope and actually looking in the brain to see what the actual nerve cells look like inside the brain. But you can try to make educated guesses by the way the patient presents, the things that they are still good at, that they have preserved, and things that they have trouble with, as well as how it's progressed over time. There are some newer biomarkers that are available where we can try to get a more educated guess, but some of those are not, at least in my experience, not widely paid for by insurance companies. So it's still largely a clinical diagnosis where you talk to the patient and family and then do an exam.
Talking with Dr. Anthony Davis, we're visiting about Alzheimer's, about dementia, and one of the main things that I can think that happens to us all at one time or another is I have trouble thinking of a word, or I forget someone's name at church or at work, or someone I see quite frequently. Does that mean I'm getting or have dementia?
No, definitely does not equal the diagnosis of dementia. Those can be very common things. One of the most common things that people present with is word finding difficulty, where it's at the tip of your tongue, but you just can't recall a word. But the textbook definition of dementia is a cognitive impairment or a memory change of some sort that begins to affect life. And so if you're still doing all of the activities of daily living that you need to do, you haven't had to get help with anything, then ultimately that would not meet criteria for dementia. And it doesn't necessarily mean you're going to go on to get dementia. It can be a very normal part of human life, but especially aging.
I think another question would be, are dementia and Alzheimer's the same thing?
They are not. So dementia is more of an umbrella term that, as I said, means that there's been a change in life because of a memory problem, but there are different causes. And so by far the most common form of dementia is Alzheimer's disease, but there are other forms of dementia, including Lewy body dementia, frontotemporal dementia, vascular dementia. There's a few less common forms as well, but that makes up the bulk of people that have dementia, but it is a diagnosis that has different causes.
Not unlike a math problem. When we look back on our days in school, there was a formula that would lead you to a final decision on that math problem. And of course, symptoms are part of the formula that you use in all of your practice there as a neurologist. What are some of the symptoms of Alzheimer's?
So I like to ask about how things are around the house. It's hard to quantify. Well, how often do you walk into a room and not know why you're there, or how often do you forget the person's name out on the street? So I like to ask about things that we do every day, and honestly take a lot of these things for granted because it can get to be a little bit harder. If the patient's still working, then I'll ask about job performance and see if there's been a decline in their ability there. But I have kind of a joke with my patients that I ask about bills, pills, and wheels. And so bills being, I'll ask who handles the finances within the family. And I'd be concerned if the patient had always done the taxes or always filled out the light bill each month. And then we got a shutoff notice, not because we didn't have money, but because they were kind of hidden in a drawer. And so then the spouse or the family member has to start helping out with that and kind of monitoring that situation. With the medications, with the pills, if you're able to handle what often is a very complicated set of medications, a lot of these patients are on 12 or 15 things as we age. If you're able to keep up with those, and I know that I take this one in the morning and this one twice a day, then that's comforting. But often we see problems where it's not going as well, that you pick up a bottle and you realize, well, I haven't refilled this in 3 months, and so I must not be taking it every day. Or if there's an accidental overdose where you've taken too much blood pressure medicine and that causes a problem, then those things start to show up. On the wheels side, of course, driving and navigation is a big one. It's a very delicate topic because I know that it involves a patient's autonomy or their ability to go the places they want to do. So sometimes patients are a little hesitant to talk about that, but their family, if they've noticed that there's a navigation issue where we're having more trouble going places even that typically would be easily remembered or very routine, if there's reports from the neighbors that you're driving all over the road, of course, tickets and accidents and those kind of things. Those are some of the hallmark symptoms that I ask about because that's where problems show up. If you make a mistake on one of those areas, it will show up to other people in the family, or you might notice it yourself, much more than I can't remember the actor that was in this movie.
Talking with Dr. Anthony Davis, we're visiting about Alzheimer's, about dementia today. You mentioned earlier that it is difficult to diagnose. More than likely, the only way is by having an autopsy. For those people that are listening today, and there are many that have already been through this path with a family member, go over a little bit about the diagnosis process and maybe about is there a battery of tests that you use to at least give you some further markers, or is it something that is fairly easily done?
It's a somewhat involved process, but it does start with just talking to the patient. I like to have a family member there often, or at least some input from the family, even if it's just a little note card that they hand out ahead of time, because sometimes the patient doesn't notice that something's going on. My wife knows that I'm in a bad mood long before I've ever realized it, and so if I'm a little forgetful, people close to me might notice that first. And so it starts with an interview where I talk to them about some of these issues that I've brought up. Often we'll go in and have imaging done, which may be an MRI or potentially a CT scan to look to see if there's any structural damage within the brain. But that only tells us really what the brain looks like, which doesn't necessarily tell us how the brain functions. So as part of the interview process, it will usually go into a cognitive assessment. It takes about 10 or 15 minutes depending on which one you pick, and I've got a few favorites that I use. But ultimately, you test different things, what we call different modalities, meaning there's a question about memory, there's some about calculation or handling money, there's a question of story understanding, and can you pick out details from a story that I've told you. And so there's some visual spatial skills and other things. So there's much more to the exam than just memory. And so you look at that and you try to decide what the patient is good at and what they may have a little bit of trouble with. And then you can also get a score that just from a statistical percentage can tell you, okay, this is probably something that's concerning.
I know one of the biggest issues in any family, especially as our parents get a little older, or even our grandparents. We're taking care of grandparents, and they get a little older, and we notice things. One of the toughest things to do is maybe bring this up. And I know in any illness, an early diagnosis many times can help make the difference between how the individual deals with that ailment, or on down the road, how serious it can get, how quickly. For the family member, and you and I were talking about this earlier, about the fact that it's not just the individual that is afflicted with Alzheimer's or dementia, but it's the caregiver as well. How does the family member, how does the caregiver make that decision to maybe mention it to the individual, or encourage the individual to go to a physician to start that process? Because it can't be easy.
No, it can be very difficult to kind of bring that up. And one of the things that I do is try to take the negative connotation of dementia away by giving them that definition that I gave earlier, because a lot of patients, when they're in front of me, if I say, okay, do you have a memory problem that has affected life, they will say, well, yeah, I kind of do. And so then just by that, I'll say, okay, well, then we're a little bit concerned about dementia. And that's not necessarily a bad word. It's just a description of what's going on. So if the loved one, if they're under regular physician's care, can always be mentioned to the primary doctor. I've been pulled out into the hallway or slipped little note cards and things like that, because often it is a touchy subject. And so if the patient is somewhat resistant or says, I don't have a problem, and you're afraid that they'll get angry about it, there are ways to communicate with the physician. But I think being open with people as they age and say, you know, Mom or Dad, you had a little bit of trouble with this, maybe we can talk about that, and try to open a dialogue and see if they're receptive about getting more into that discussion.
I know you and your staff really go the extra mile to be open for questions from your patients and caregivers. And so many times people do feel a little, if they're not a physician, they don't feel comfortable getting into the weeds, asking those questions that maybe they would have difficulty understanding. But one of the questions I think a lot of people think about, what actually happens to the brain of an Alzheimer's patient?
So it's a degenerative disease where the brain has been damaged over time. When Dr. Alzheimer looked under the microscope, he saw blobs and little balls of tangled yarn, and those are called plaques and tangles. And we now know that the plaques are made out of a protein called amyloid, which is a normal occurring protein, but it can collect in an abnormal way in the brain of a patient with Alzheimer's disease. The little balls of yarn are called neurofibrillary tangles, and those are made of a different protein called tau, spelled T-A-U, and that's a protein that collects inside the nerve cell, and so you can see those under a microscope. And so over time you get an increase in these abnormal protein collections that start to disrupt the way neurons or nerve brain cells communicate with each other, and those processes are broke down. On the overall side of the brain, you'll get shrinkage, which is a naturally occurring thing. Your brain peaks at around age 25 to 30 as far as how much it weighs. And then every year from there, your brain weighs a little bit less. And so if you live to be 150, your brain would kind of look like a walnut. But over time, there is normal shrinkage in the brain. But one of the things we can see on MRI is if there's a abnormal amount of shrinkage, or what we call atrophy, where it's more than what we would expect for this person's brain, because we would normally expect an 80-year-old brain to look different than a 60. But if you have a 60-year-old patient who looks like they have an 80-year-old brain, then that would be more concerning.
Neurologist Anthony Davis along with us. We're talking about Alzheimer's and dementia. Just like there are stages in life, are there stages of Alzheimer's?
There are. And so some of these are a little bit arbitrary, as far as there's not necessarily a new treatment that springs to life as you move from one stage to the next, but most of the staging is based on the patient's abilities to do things around the home. If you've got somebody that's pretty completely functional but maybe just needs a little bit of help with their keeping their bank straight or keeping their checkbook balanced, then that would of course be very minor, all the way up through somebody who really needs full-time care and has difficulty with toileting and incontinence issues, trouble bathing and trouble dressing. That of course would be towards the more of the end, or if the patient gets where they're just not able to speak at all and becomes more bedbound, towards the very latter stages. And so the staging is not as important as far as treatment is concerned, but it can kind of tell you exactly where the patient is and maybe how quickly they have progressed. If you've known them for a long time and they're still pretty functional, that's overall a good sign.
No matter what your illness, we always want to have hope.
Yes.
We want to have hope. How, and I bring that up because I think the next couple of questions go along with that. How is it treated? Can it be cured, or can the patient get better?
So, unfortunately, there is no cure, but there are treatments. And so, one of the first medicines that the doctor may prescribe is attempting to boost a chemical within the brain called acetylcholine. And so there are three main drugs that do that. The most common one is called donepezil, and it is attempting to boost the amount of acetylcholine within the brain, which has shown improvement in cognition in patients who've been on that drug. A lot of times when I'm face-to-face with patients, the patient and family doesn't necessarily notice a lot of difference, but over studies and over time, it clearly does change the way the patient progresses. There's another one that's called Namenda, or memantine is the generic name for that, and that works on a cellular channel within the neurons to try to slow progression with that as well. And for a long time, those were the only two main types of medications that we had to treat dementia, especially Alzheimer's disease. Even the new medications that are coming out now and have been in the news quite a bit, unfortunately, they don't really seem to turn the clock back or to cure the patient or cause them to go back to a normalcy, but it does seem to flatten out the decline where there's not as steep a slope over time. We're still looking for something that can turn the tide and actually cure the patient.
I would guess children of those with Alzheimer's. And Alzheimer's, I know, can happen to folks. They have early onset. It can happen, I would guess, even in people's 30s, 40s, but it's more general later on. But when you have children or grandchildren that are going through this, that are somewhat caregivers, a question always comes into their mind: is this genetic? And does that mean that I will eventually get Alzheimer's or dementia?
So very little of this is set in stone, is what I usually tell patients, that we draw an arbitrary line at the age of 65, where if you start having dementia symptoms before 65, then that's considered an early onset, and after 65, it's considered a late onset. The early onset dementias can have a stronger genetic component where we do get more worried about it following through a family tree. Often it is very apparent that the great-grandfather had it, and then the grandmother, and then the father. It goes directly down through the family tree where you can look and say, okay, most of my aunts and uncles have this as well as my parent. And that is more typical in the earlier onset dementias. The later onset dementias, there is a genetic risk factor, but it's not set in stone. So if you have a first degree relative, which would be a mom, dad, brother, sister, child, who has Alzheimer's disease, you're at about a 10 to 30% higher risk than someone who doesn't have that relative. But of course, that's not anywhere near 100%. So I try to be encouraging to patients that if your parent or loved one has a late onset, it does not mean that you're going to go on to get it. In fact, a very common gene that is present is called ApoE4. And even if you have 2 copies of ApoE4, it raises your risk somewhere around 10 times what the normal non-carrying population is. So it is a risk factor, but it does not guarantee that you're going to go on to get dementia.
We watch TV all the time, and it seems like every night there's a new medicine for something. And sometimes that can be encouraging. Other times it can be very disappointing. And you mentioned earlier, there are some new medicines. If you'd like, talk a little bit about that. And for those individuals that see this, that doesn't necessarily mean they need to give you a call and say, we need to put my dad or my mother on this medicine, because sometimes that can be not the best process, I would guess.
These medicines are not perfect, unfortunately. We're really excited because, as I mentioned, we've had the same few medicines for decades now, and so it is a very exciting way of looking at things. If you watch these ads on TV, a lot of the new drugs end in MAB. M-A-B will be the last 3 letters of the name, and what those are antibodies that have been tailor-made to attack or to affect a certain target. And so there's treatment from anything from psoriatic arthritis or rheumatoid arthritis all the way through just headaches that have been these monoclonal antibodies or MAB drugs. And so what is being worked on now and what's been FDA approved are a couple of medicines that are targeting amyloid. And so these go in and they're laser focused to try to knock out amyloid within the brain, which I mentioned collects abnormally in the brain of patients with Alzheimer's. The 2 that have been approved are aducanumab and lecanemab. It looks probably more promising for lecanemab, which has recently got its FDA approval as a full and not a accelerated. They went through the normal process, and so that one tends to be a little bit more promising than the aducanumab. There's another one called donanemab, which is still in the process of being approved and studied. Those drugs go in and they seem to be pretty good at attacking amyloid. That even in rats, they can go in and give a rat artificial Alzheimer's disease and then try to knock all the amyloid out with these medications. And so it's been pretty consistently proven that these drugs go in and attack the amyloid. What is a little more disappointing is the effect that has on the patient as they walk around. And so it does seem to help slow the disease, but it is not a cure and it does not necessarily turn back the clock. These drugs have not been started being given in Arkansas as far as I know. I'm in contact with another behavioral neurologist in Little Rock, and we're gearing up and starting to get that process, but there's a big issue with payment. That these drugs are given by IV, where you go in, similar to chemotherapy, you get it every 2 weeks in the case of lecanemab, and it's about $20,000 a year. And so I usually tell my patients, I don't care how great a medication is, if I can't get it for my patients, it might as well not exist. And so at this time, CMS, or the Medicare, has said that they're not going to pay for this without more data. That's being argued about in Washington. There were recently hearings concerning this very fact. And they're not allowed to say this, but I personally believe that cost has to play a role in this. If you consider that approximately 4.5 million people in the United States are living with Alzheimer's disease, this would be an enormous financial burden for Medicare if they start to pay for these drugs. And so that's something that's going to have to be figured out with lawmakers to allow these new exciting drugs to be able to be given.
How important is it as a caregiver, and for that matter as a physician, to evaluate the side effects? Because no matter, even aspirin, if you take it improperly, can cause side effects. I'm sure that with these MAB medicines and others, there are side effects that go along with this, and you kind of alluded to it. How important is it for the caregiver to evaluate, along with their physician, the benefits of how much better the person is when you look at the side effects that it can cause?
Yes. So during the studies on this, they were following patients quite closely, and they were doing extra scans, including MRIs, that they normally wouldn't do. Normally, when you take your first dose of a medicine, the doctor doesn't order a scan on your brain the next day to see what happens. But while they were studying these, they were doing extra scans, and what they found is that some patients had bleeding in their brain, and other patients had swelling. And so they've called those amyloid-related imaging abnormality, or ARIA is the term that we use for that. And we divide it into ARIA-E, which the E stands for edema or swelling, and then H for hemorrhage. And most of these patients were asymptomatic, that we would not have known that there were any changes within the brain had they not had the scan the next day as part of the study. But that is concerning as a physician, because any bleeding in the brain we typically consider very serious. And so we're still trying to devise how we're going to monitor these patients, especially for a medication that's given outpatient. And so these are challenges that are being looked at on a national basis to try to get a good protocol where, if there are changes within the patient that would warrant follow-up scans, or should a follow-up scan be done just normally? And those are issues that are going to come up and have to be addressed before this drug is in widespread use.
As a neurologist, I know you keep up, and their continuing education is part of your life, keeping up with some of the JAMA updates and many, many other periodicals that are available online and in hard copy. What's in the background as far as medicines that are being discussed or talked about or are nearing being approved?
So we're still a ways away, but another drug, or another thing that I mentioned earlier, was that there's an accumulation of that protein tau within the brain. And so there are drugs that are being looked at that would go in and do basically the same thing that the amyloid drugs are doing, but aimed at tau. And so in the future, as these get FDA approved, it is understandable that it may end up being more of a cocktail of medications, where the patient takes one for amyloid and then they go on and take one for tau as well, which is very similar to the way we treat cancers, that it's unlikely that a person is only on one chemotherapy. Will have different targets for whatever cancer they have, and so they may be on 2, 3, or 4 medications. And so as these tau drugs get closer to widespread use, then it may be that we're mixing them together. But that's still a ways off.
Do you think that, and of course we see specialists that move to very particular phases of all diseases. Is there a movement out there for young physicians to try to find better ways to diagnose Alzheimer's and dementia without having to use that autopsy? Is that something that they're working toward?
Absolutely. So we call those biomarkers, which is basically, if you have blood drawn at the doctor, that's technically a biomarker to see if you're anemic or have an infection or whatever it is that they're looking for. But in the case of Alzheimer's, they are working on a blood test to be able to pick up amyloid within the bloodstream. The way that we look for it now is actually with the spinal tap, which of course is not an easy test to put somebody through. It can be painful, and people are scared of it often. So that one's not used as much, and so if we get the blood test, that's going to be a big help. As far as imaging, there are special PET scans that can look for amyloid within the brain. Personally, with my clinic, I have not had good luck in getting those approved through people's insurances, so we've kind of hit a wall there. You can also look at the amount of glucose or sugar that the brain uses, because areas that are not running very well won't use very much sugar, which is the main source of energy for the brain. And so you can do a special PET scan for that as well to see if there's areas that are not as active. Then with these scans, you put it together with the clinical aspect of the patient and try to make a full story. Something that St. Mary's Hospital has started doing, as has Dardanelle through Conway Regional, is they will do an MRI with what we call volumetrics, which basically takes a three-dimensional picture of the brain, which we're already doing with MRI, but it allows for some measurements to be made. And so I alluded to the shrinkage that happens within the brain earlier, and we can actually get some hard numbers now of, yes, this brain is more shrunken than we would expect for a person this age. And so this is something that the local hospitals have been kind enough to start including for us, because it has not been paid for. They've just added it on to the study as something extra for my dementia patients. And so as we see that become more common, it will give us another piece of information that we can tie into the whole picture.
Every family, I think, or I would say a majority of families in one way or another, have been touched by Alzheimer's or dementia. Mine is no different. And so I could spend all day long talking to you, but you have patients to see, and we would love to get you back and talk again. If people have questions they need answered, would you like for them to email you or to call your office, and maybe we can touch on some of those in a future get-together?
Absolutely. I love talking about this, and I love educating patients and families because it makes the visit better, where they can use the same language that doctors use and tell me what's going on. And so it improves communication, and it helps people understand what's going on. So my email address is on our website, which is davisneurology.com. My email itself is drdavis@davisneurology.com, no underscore or anything, just Dr. Davis. And then they can always call 479-880-0101, and we'd be glad to try to figure out how to help.
Dr. Anthony Davis, God bless you, sir. We appreciate you.
Thank you, sir.